Good afternoon. I'm so confused with the time zone change right now. I'm sorry. Good evening, everyone. It's Debbie Hill-Basell. It is Sunday, November 3rd, 2019, and tonight is case list review. And to all of you who are taking your test next week, all of us wish you the very, very best of luck. All right, so how to participate today? There's a little orange arrow up in the right side of your screen that basically opens and closes your panel. The vast majority of you are on mic and speakers. However, if you need to click on use telephone, you just click on that little circle on your the panel on the right side of your computer screen, and it will give you a phone number, an access code, and a PIN number to use. With regards to participation, you just raise the little your hand to volunteer. And you know what's always tough, especially as we start getting so many people on the webinar, is how do we get to everyone without always calling on the same person? And each of us faculty members try everything we can in order to keep it as fair as possible. We even look at who's been called on over the previous couple of weeks before we do the webinars. But this is what I'd like to do tonight, since Monday is the first testing. If anyone is testing this upcoming week and has never been called on, when I ask for volunteers, I am going to actually ask for those patients to raise their hands first. Oh, and then the only other thing before we go to volunteers, this has happened twice so far this year. My internet is a streaming service where we live. I don't actually have fiber internet or fiber optic cable. So sometimes I'll lose audio. If I lose audio, just stay put. What I'll do is I can switch over to phone, where I can click on dial on the phone, and then I can join you. Hopefully it won't happen, but if it does, you know what to do. So now what we'll do, let's go ahead. I'm going to actually lower everybody's hand who's got it raised. And now I'm going to ask for anybody who is testing next week and has never been called on. I want to get out of my PowerPoint here so that I can get to pull up the case list. Okay, so anyone, let's see here, anyone who would like to be called on who's testing next week. Let me see, let me just scroll through here. All right, looks like there's no one. Anybody who is testing next week and hasn't been called on in the last week, please raise your hand. Okay, so now I'm just going to say, okay, well, here's Danielle. All right, Danielle, let's see. I don't see any way to get to you. I don't see, you don't have, where I would click on you, there's not a microphone or a phone. So I don't know if you're just listening, but I can't reach you. So double check that. All right, so then let's see what else. How about anyone who hasn't been called on in the last week? So I don't care when you test it, but if you've not been called on in the last week, let's go ahead and get started. Let's start with Melody. Hey, Melody, how are you?
Hi, good, thank you.
Good. I almost start feeling like Bob Barker, you know. Anyone who's not done this, let's go. So come on down. When do you actually test?
In December.
In December. Okay, well, it's coming up sooner than we all want to think about it. But you know, at this point in time, sometimes I think it's just good to get it done with. So you're a general OBGYN, correct?
Correct.
Okay, so what case list would you like to do? And do you have also, I'm going to ask if you have a particular case that you want to just make sure that somebody goes over, we can do that too, but it's your call.
I don't think I have particular cases, and I really haven't been super good about looking through my whole list. So anything in OB I think would be good.
All right, let's do it. We'll just pull something up and then let me find you.
Seeing if there's anything I could look at.
So let's see if you're under M or Z, that they do this in the craziest way.
I think I'm under Z. I think I saw my name
Z,
before.
yeah, because some, yep, there we go. I gotcha. Yeah, because some of them, they like put them under their first names. Whatever, it doesn't matter. It is what it is.
Oh,
What
asthma might
state
be a
are you?
good
Oh,
subject too. I have some asthmatics.
all right.
I'm in Texas.
In Texas. Okay. All right, here we go. And is that just mixed in, or is it under the like the medical problem
It
issue?
should be under the in pulmonary or endocrine or something like that.
Pulmonary. Yeah. Let's see. Let's just get
Yeah,
going here.
cardiovascular of pulmonary. It's 87, 88, 89. I've got a couple of them there.
Okay. All right, let's go to the harder one, patient number 88. So, well, and let's just go over it in general. So, we know that asthma is going to be the most common pulmonary disease that we deal with in pregnancy. Okay, so tell me, how do we, before I get to these specific patients, how do we classify asthma?
So there are, first you can have either intermittent or mild intermittent, and then there's mild persistent, moderate persistent, and there's severe persistent. And those are based on how often patients are using their inhalers, how many attacks they have per week, also their FEV, which I couldn't tell you the actual percentages, but I know they do kind of look at their FEV total.
Okay, and then with regards to, let's talk about mild intermittent. What do they usually have to do?
So mild intermittent patients usually will only need a PRN inhaler, so just a short-acting beta-2 agonist inhaler.
Okay, so then with moderate persistent, which is your number 88, she's on it. It looks like she's on a combination inhaler, the low dose glucocorticoid long acting beta agonist. Which do you recall which one she was on?
She was on, I believe, Advair.
Okay, yeah, that's definitely one of them. Now, do you manage the asthma, or is that where your MFM comes into play once they get above mild intermittent?
Right. So mild intermittent, I manage those because once they get above that, then they do see the MFM. So I always give my patients the option whenever they have any comorbidity, if they want to see the high risk physicians. But specifically for these patients, I definitely have them see maternal fetal medicine and manage that throughout the pregnancy, as well as the
So,
antenatal surveillance that gets followed with maternal fetal medicine.
okay, so if somebody has more than mild intermittent, so patient 88, moderate persistent, how does the asthma affect the pregnancy?
So we know that if asthma isn't very well controlled, then the patient may have their exacerbations may go up, particularly depending on the time of year. So they may have a higher frequency of exacerbations. They might be worsened exacerbations, even potentially requiring hospitalization. And so we at times will need to put them, a lot of these patients are basically only on an inhaler when they're not pregnant. And then once they're pregnant, given that their cardiovascular system is upregulated in pregnancy, then they sometimes will need a daily medication, as in this patient. In terms of the pregnancy, we would follow the antenatal surveillance is really basically growth every 4 weeks until delivery. There's no indication for an induction or early delivery with the asthma unless there was significant disease. But it's really just kind of following and making sure that the growths are appropriate.
Okay, why would asthma affect fetal growth?
If you're having poor oxygenation, then I would expect that potentially you're not getting enough nutrients into the fetus throughout the pregnancy.
Okay, patient, let's see, let's go back to, so that's how asthma affects the pregnancy.
Mhm.
And then I guess you did already do how the pregnancy affects asthma because you talked about with the upregulation and then possibly more frequent attacks and needing medicine. Tell me about the little pulmonary function tests that they do.
So, especially in the beginning, we will have patients do their own, oh, what are those called? Now I'm blanking.
The spirometer.
Yes, so they take the spirometers home and be able to see what their own FEV is, or forced expiratory volume, and they can measure that rate and see if they stay above like a good 80%, and if they're lower than that, then they should, either be transferred into get a different medication, or potentially, obviously, if there were worse symptoms, then potentially hospitalization.
Correct. And if they know kind of what their baseline FEV is, then when they go to check, and if they were less than half of what their normal baseline is, what would you tell them to do? What's the significance of that?
If it is less than half, they would need an upright to go a step above on their medications. So the medications are ordered through steps.
So my understanding is if they get a FEV that's less than 50% of their baseline best, they're like supposed to head to the emergency room
Oh, okay.
because of just impending possible horrible severe asthma attack.
Okay.
Let me see what else. Matt, you did great. I mean, I hate asthma. I hate asthma
Yes.
questions almost as much as I hate hepatitis B questions. I just don't like them because I just bleh. What else are we going to make sure this patient gets during her pregnancy? We were going to recommend everybody get it, but especially with asthma
Yeah.
and compromised pulmonary function.
Definitely her influenza vaccination for sure.
Yep, so that's the big one that we would want to make sure she gets. Yeah, I can't think, I mean, if they ask you more questions than that, Melody, about asthma, then they're just pushing the extent of your knowledge. Yeah, I mean, I
Okay.
guess the only thing I know is if they were on just a steroid inhaler, that budesonide has had the most safety in pregnancy. But again, I'm not even sure which one's in Advair. I know it's not budesonide, which is Pulmicort. But, obviously the MFM made the call that this is going to be just fine. Obviously, this kid did not have any problem with growth.
Right. Yeah, and that's
The
what I was
moderate.
kind of trying to look for, if there was anything else. I mean, I think we just technically follow patients when they have any comorbidity just to be on the safe side, but not really too
Right.
much asthma.
Right, exactly. But there is a practice bulletin on asthma and pregnancy, but it hasn't been updated in like 12 years or something. It's really, really old. Because I remember when you go scrolling through the practice bulletins, it's like way down there with gestational trophoblastic neoplasia, way down below. But no, I think you did a great job. I don't really have any other questions, but here would be a question. But patient 87 and 88, their kids were huge. Did you have a suspicion that those babies had that high of an estimated fetal weight prior to delivery?
So I will normally do a growth ultrasound for all of my patients if we're not following them for growths throughout their pregnancy for a medical indication at 34 to 36 weeks. And then based on that EFW, we will either proceed to subsequent ultrasounds or just kind of leave that as the average to get us to about delivery time, 39 to 42 weeks, et cetera. So usually if they were, I would have done another one. So both of these, honestly, they were percentiles were probably in the 70th to 75 percentile. I get
Okay.
more concerned when it's like when it starts reaching the 80s, then I might do a subsequent follow-up with those.
So if you did suspect, like patient 87, that this baby was well over 4,000 grams, would you do anything different of how you would counsel her about options for delivery?
Yeah, so once we start getting into these percentiles, I do discuss with them that the ultrasounds can be off, plus or minus. I believe it's about 500 grams either or. But once we start getting into those estimated fetal weights of the 80th percentile or above, I discuss that it's possible that the baby may be on the higher end, and the potential of either doing an elective induction, not for microstomies, we don't do inductions for that, but just if they wanted to, we could think about 39 weeks to try and avoid babies getting much, much bigger. And if we ever did get somewhere to, 5,000 grams for one of my patients, we would discuss elective C-sections as well.
Okay, good. All right. I have no further questions. You know what was interesting though? I was giving a individual mock oral with one of the candidates, and I was looking at her OB case list, and there were a lot of primary C-sections for suspected macrosomia. So I was like, okay, well, but this one was 4,000 grams, whatever. The lady wasn't diabetic, but you know what was very interesting? It was actually the policy of the MFMs at their hospital. They actually went back and reviewed 12 years of previous data at their hospital and found that when they weren't offering the C-sections for 4,000 grams and above, that they found that there was an unacceptable fetal risk. So again, I said, well, that's what you're just going to have to tell the examiners. This
Yeah,
is the policy of the MFMs at your hospital. So,
yeah.
but yeah, if you look at what ACOG says, it's 5,000 if they're not diabetic or 4,500 if they're diabetic. So,
Right. Yeah. I actually have a case where I have a patient who elected to do a primary C-section given the ultrasounds, and we suspected macrosomia, and her baby was only 3,500 grams.
right, and it happens. You counsel them, but you know what? Here's what I say is the not wrong thing. You didn't say to her, "You better have a C-section because something bad could happen." You discuss with them.
Right.
If we allow people to say, "You know what? I would just like a C-section," and we can do that, then what's wrong for them to say, "I know my baby's really big. I just prefer not to worry about this." I mean, if we let them just say they just want one because they want one, and
Yeah.
ACOG says we should respect that. Do you
Right.
know what I
Right.
mean? But
Hmm.
counsel them about the benefits and whatever. So, yeah. So I think that you could very easily defend that you counsel the patient about the benefits of a vaginal delivery, what the discrepancies of ultrasound at the third trimester, that if she wants more children, especially to do a C-section now and get into all that. But despite all of your education and counseling, the patient still elected to have a C-section, then you respected patient autonomy.
Right. Right. Great.
So there you go. Okay, thanks, Melody.
Thank you.
Hey, I'm trying to get Lauren, it looks like you're self-muted, so unmute yourself. There you go. Oh, now I got two Laurens. All right. Laura, let me click you off. And then Lauren, you're there? Lauren? Lauren? Ramos? Okay, I don't know why she can't hear me, but because she's unmuted. All right, let's go to somebody else. Dana?
Hello? Yes, hi.
Hey, how are you?
I'm good. How are you?
Good. Hey, so when do you test?
Also in December.
In December. Okay. So what case list would you like to do?
Can you do GYN, please?
Okay. And are you a general OBGYN?
Yes, I am.
All right. So let's see here. Let's go back. What state are you in?
I'm in New York.
In New York. Okay. So I'm going to start scrolling.
I think it's my
Here,
last
is it?
name.
Yep, here you are. Okay, got ya. Do you have a particular case that you would like to do?
No, not off the top of my head.
One that's bothering you maybe more than the other ones?
I have two cases where I did both a hysteroscopy and then an abdominal procedure.
Okay, let's look at where those were. So under the same anesthetic, right?
Yes.
Is that what you're saying? Okay, so it's not here. Let's see where you are. Okay.
Abnormal uterine bleeding or abdominal myomectomy.
Okay, I'm not, am I missing some? Oh, the abdominal, the DNC
Yeah.
polypectomy?
Mhm.
Okay, all right, let's look at that one then. All right, so you have a 28-year-old, 38, G3P3, pelvic pain, abnormal bleeding, endometrial polyp, 5 centimeter intramural myoma. So before anything, before we even talk about that, so tell me how you evaluated her prior to taking her to the OR.
So the patient presented complaining of pelvic pain and abnormal uterine bleeding that was spotting in between her cycles. So I took a history and a physical exam, and most pertinent with her history was severe pelvic pain during her menstrual cycle that was getting progressively worse, and also significant was the intermenstrual spotting. So I performed a physical exam. Pertinent on my physical exam, I saw a prolapsing cervical polyp, and also on a physical exam, I felt a kind of bulky myomatous uterus, and ultrasound showed a thickened lining at the time, like a focal thickening, also consistent with a polyp, and the intramural fibroid. I counseled her for removal of the cervical polyp at that time. We removed it, sent it to pathology, and then the patient, and I had her come back to reevaluate the lining of the uterus during the day 3 to 5 of her cycle to reevaluate the uterus for thickening for a polyp, and we confirmed that there was suspicion for a polyp, and we talked about management options. The patient declined medical management for the bleeding or for the pelvic pain. She didn't want any hormonal treatment, and she wanted to preserve her uterus, not because she was planning on conceiving, but because she wanted to preserve her uterus. It was her personal decision, and we came up with the plan for a diagnostic hysteroscopy to evaluate if there was any more polypoid tissue left, and for the abdominal myomectomy.
Okay, and what order did you do those in?
So I did the polypectomy first, and then I did the myomectomy.
Okay, so you go ahead, you do the hysteroscopy, you do a polypectomy DNC, perfect. Then take all the instruments out of her vagina. I'm sure you gave her a prophylactic antibiotic for the abdominal myomectomy, and I'm sure you did what? Fan and still incision, right?
I did a mini lap. It was very, yeah, but it
Okay,
was in the
where
fashion
was
of
the
hand still.
myoma? Was it anterior wall?
It was anterior lateral,
Okay.
and certainly intramural. It was like a, what would I call it? I would call it a FIGO type 4, I think that's what I would call it.
Okay, so tell me what you did to try to minimize bleeding.
Okay. To minimize bleeding during a myomectomy, I administer dilute vasopressin, 20 units in 100 cc's of normal saline. I inject it right into the serosa in the direction of which I'm going to be placing my incision. Also, I dissect with cautery to minimize the bleeding and to perform the procedure in an expeditious manner. If I have multiple myomas or I'm concerned for a lot of bleeding in a patient, I'll also place a tourniquet
Okay,
around the
and
base
so
of the
what
uterus.
prior to doing the myomectomy, what did you counsel the patient are the risks of a myomectomy?
The risks of gynecological surgery in general, especially myomectomy, are pain, bleeding, infection. So intraoperatively hemorrhage, especially that increases with the increasing surgical time, the increased size of fibroids, and the increased number of fibroids. Also intraoperatively, there is a risk of hysterectomy for any woman undergoing a myomectomy if there's uncontrolled bleeding. There's also a risk of damage to nearby structures. Most significantly for a myomectomy would be the fallopian tubes entering the endometrial cavity, requiring a future cesarean birth and no longer vaginal delivery. Also the ureters, the bowel, the ovaries, kind of any nerves, arteries, and vessels in the area.
Okay, and when you I'm sorry, when you counseled
I,
her about the abdominal myomectomy, what did you tell her was the likelihood that she could perhaps develop more myomas in the future?
Her likelihood is low because she only has one singular fibroid. If she had multiple fibroids, I would tell her that her likelihood is high, closer to maybe 50 to 80%.
Agreed with everything you said. You've done a really good job, but I actually interrupted you. Tell me what you were going to finish saying.
Oh, I was going to tell her that postoperatively to experience pain and sometimes irregular bleeding until her cycles resume, and that sometimes patients experience fevers within the first 24 hours, and it's not necessarily an infectious cause.
Yeah, especially with the myomectomy. So what's causing that temperature elevation in that first 24 hours?
I think the theory is that they're released like pro-inflammatory cytokines with the removal of a myoma.
Exactly, especially from tissue damage, etc. And we're definitely like damaging more tissue when we're doing a myomectomy versus just kind of cleanly taking out a uterus, etc. So let's go back to the pain management. Most of the patients, when you've done surgery, you don't write under your treatment pain management and then put as a complication post-op pain on post-op day 10. Tell me about this patient in pain.
So the patient postoperative course was very normal. She was discharged on postoperative day 1, which was her hospital day 2, and she called me 10 days postoperatively after having passed all her milestones and doing well. She experienced severe left lower quadrant pain, severe pain. I called her back into the office to reevaluate her. Her incision was healed. There was no erythema. There was no incisional tenderness, but she complained of kind of shooting pain across the left side, which was a very something that I really haven't seen with abdominal incisions like that. Usually if there's nerve entrapment, it usually happens after a laparoscopic procedure, and it's immediately noted post-operatively in the recovery room. And what you do is just release the stitch and maybe just glue the skin back together or let it heal on its own, and the patient has immediate pain relief. This was a very different scenario. This pain developed slowly and became very severe and very debilitating. The way that she described it made me think that it was neuropathic pain. She declined any intervention at first, and I saw her within the course of the next 2 weeks, and we did some imaging, and we found that there was a 10-centimeter hematoma on the rectus muscle, probably impinging on some nerves, and she was being followed, and it was stable, not expanding. And me and her neurologist, who she sees for migraines, we both monitored her and treated her with gabapentin, and it resolved over the course of the next 2 to 3 weeks.
Fascinating. So she had, was it underneath the rectus muscle, this hematoma?
No, it's in the rectus muscle.
It was in the rectus muscle.
Yes, the MRI described it as in the rectus muscle.
Wow. And you even did a mini lap. Isn't that interesting? So you wonder, yeah, that is interesting. Do you have an explanation for that or a possible explanation?
I think there was a fluid capillary bleed that accumulated and then was self-limiting. And by the time it accumulated, it caused some possible nerve entrapment in the area that caused her pain.
Yeah. What else could cause left lower quadrant pain after she's post-op day 10?
It could be a fascial suture. It could be constipation if the patient is taking narcotics. There could be an abscess. There could be infection on the skin. If the patient is older and maybe immunocompromised, she could be having herpes zoster.
Yeah, because to you it really sounded, Well, and again, if it wasn't necessarily a nerve pain, I guess also if she's 10 days out and she's 38, I guess she could have a developed like a hemorrhagic corpus luteum cyst or something
Okay.
on the left. Do you know what I'm saying? I mean, but I was definitely thinking my other thing with the left lower quadrant was bowel, constipation, narcotics, not moving around as much, etc. But no, that's very interesting. So yeah, good. So you got some imaging. When she came in with this pain, she had obviously no fever, chills, nothing like that. Did you do any labs on her when she first presented?
I did a CBC to evaluate her
Mhm.
white blood cell count and to compare her hemoglobin to that of pre-op and immediately post-op.
And white count normal and
Everything
CBC
was
stable?
very normal and reassuring. Yeah.
Okay, well, good. Well, that's interesting. I wonder what nerve it was. I'm sure the neurologist could tell us that was being compressed, but I hate nerves too. You know, but good. So it resolved and you put her on gabapentin, which would have helped her migraine some also. So there you go. All right, great. Now, the big question is for that you had is, but I did a hysteroscopy DNC and then did an abdominal myomectomy. But I see that as totally appropriate because you were evaluating two different things. One was the abnormal bleeding, the intermenstrual bleeding, and the polyp that you documented by ultrasound that you needed to get rid of. And then she's under anesthesia anyway, and she's having this pain with this myoma. So then you go above and you do the myomectomy. So although that's quote not, you don't see that commonly, it makes total sense to me.
Okay. Thank you very much.
Okay, thank you. Hey, is it Farhio?
Yes,
Okay, all right. How are you doing?
good.
Good. And when do you test?
January.
Okay, and your general OBGYN?
Yes.
Okay, and what case list would you like to do?
I actually wanted gyne. There's a particular case that I wanted for you to take a
Okay,
look.
then I will open that back up again, and you're right here. First one.
Yes. I think it's
Okay,
patient 24.
okay. That's bad when you know the number right
I know.
offhand, huh? That's always a telling sign,
I
like, oh,
know.
this is one this poor woman has been losing sleep over, right?
And honestly, when you look at it, it looks like a straightforward case, but there's one particular thing under the complication that I wanted to kind of go over.
Okay, all right. So let's just go through it just normally. 43-year-old comes in with abnormal uterine bleeding, and you did one of the things that you did is an ultrasound, and it did show polyps. But in
Mhm.
general, 43-year-old comes in with abnormal bleeding. Tell me what your differential diagnosis and how you're going to evaluate her.
Um, it really would depend on the type of normal uterine bleeding she would have, whether she's having regular heavy menstrual versus an ovulatory type of bleeding. I would get a good history on that. And then my differentials really would be based on, given her age, is it perimenopausal bleeding? I would worry about if there's endocrine abnormalities like a thyroid, as well as prolactin, if she's really having no periods at all. I would worry about if she's on hormonal therapy, if she's been on Mirena for a very long time, is that what's causing it now, where she's worried about having no bleeding or just having worsening of her irregular bleeding? I would worry about structural causes like a polyp, a fibroid. I would also worry about any type of medication, like if she's on anticoagulation or so.
Okay, so tell me, she comes in, you do her history, you do her physical. What labs are you going to do? And obviously you did an ultrasound, but tell me what labs you did.
I would definitely do a CBC just to make sure she's not too anemic. With her abnormal uterine bleeding, I would rule out a pregnancy, get a pregnancy test. I would get a thyroid test, prolactin, based on if she's having an ovulatory bleeding or not. I mean, at 43, I'm really not worried about von Willebrand or so, but if she's never been tested, I would worry about that and would want to get a test on that too.
Okay, so you're saying Who would you do a von Willebrand on?
If she was younger,
Yeah,
in
okay.
her, yeah. But let's say if she's never had it done in the past in the workup and previously, and if she's not fitting into the other differentials, then I may add that.
Okay, more like a secondary line.
Yeah.
Oh,
Yes.
yeah, got you. All right, yeah. All right, so basically her CBC is normal, pregnancy, or maybe it's even a little lower, but her TSH is normal and her HCG is negative. So you're right. If she's having frequent heavy menses, you're going to get CBC, TSH, HCG really on anybody with abnormal bleeding. Anybody with abnormal bleeding is going to get an ultrasound, because how are we going to know if they have an endometrial polyp or a submucous myoma? We cannot feel that no matter how good our pelvic exams are. So that's pretty standard on all abnormal bleeding. If you suspect anovulation or infrequent menses, then you're going to add in prolactin and FSH. Okay, and then if you think it's a PCOS, you go down that whole pathway. All right, so anyway, so now you know there's a structural cause, there's a polyp. So you did an operative hysteroscopy, DNC, and got back benign polyp. So hopefully you fixed her. But then tell me, let's talk about the complication.
So everything seemed to be going appropriately. Uncomplicated hysteroscopy with a very small fluid deficit. Didn't had any bleeding when I was done. I looked at the tenaculum sites. Everything looked good. She was homeostatic, and we ended the case. Then she went to recovery, was doing well, and then at the same time, this is the case that I did when I was on call. So an hour later, I get a call from the nurse saying that patient overall is doing well. She's not complaining about anything. Her vitals are stable, but she's going through a pad every 15 minutes and has now soaked 3 pads within the hour. And I said, why haven't I been called? But regardless, she said that you need to come and evaluate her. And at the time that she called me, I was actually in the middle of pushing with a patient. So by the time I went down and evaluated, it was actually more bleeding than what was told to me over the phone, but still hemodynamically stable. Patients still doing great. I tried to do an exam at bedside just because patient didn't want to go back to the OR again, but it was really difficult with given how much bleeding she was having. And so I decided to take her back to the OR. With the discussion with anesthesia, she really wanted just sedation rather than being put to sleep, but that worked really well. Once I got in, I got a good visualization. I realized that first I was really concerned if the bleeding was from the uterus, like a perforation that I missed. But once I went in there, it was lots of clots I had to take out, more bleeding. At this time, we're almost at 700. And then by the time we got a good visualization, it was really bleeding from what I saw clearly was the anterior tenaculum site that was profusely bleeding. And so I placed a stitch, bleeding got much better. And then with a better evaluation, also I placed the tenaculum at the posterior aspect of the cervix, and that also was bleeding. And so I also placed a suture there too, and bleeding got much better and did really well. But for me, what I was really concerned is that at the time when I was doing the case, everything looked hemostatic, and I actually looked at it. I usually take good 5 minutes before I really get out to see if the bleeding is if there's any bleeding or not. And I don't know how to explain how I missed that, and to have about 750 blood loss, that's what I'm worried about.
Okay, so let's just think about this. Why would she start bleeding afterwards? I mean, that is weird. Do you know what I'm saying?
Yeah.
Because most of the time when you take that tenaculum out, I'm trying to think, okay, was her blood pressure lower? Did they accidentally give her a bunch of heparin? I mean, you know what I mean? I know that sounds crazy, but I'm trying to think, why would she not be bleeding when you looked, but then she started bleeding afterwards? So no, I would explain it exactly how you explained it to me. If the examiner says, why in the world did she have 750 cc's of blood loss from this? And was it truly a laceration, or was it just the puncture sites where the tenaculum was?
It was truly a laceration, and that's the part that really threw me off. There was the posterior aspect of it. I know the tenaculum side did come off during the procedure, but when I put it right back, it wasn't bleeding, and it just looked like a puncture site, and it wasn't concerning when I was done at the end of the case. But the anterior aspect truly was a laceration, and that's what threw me off. It didn't even come off, so I'm like,
So you're saying you did not see the laceration and it
No.
wasn't bleeding. Okay, so that's what you would say. So at the end of every case, I always look very closely, look for any evidence of excess bleeding. I look closely when I take the tenaculum off for any uh, lacerations or bleeding, and everything seemed to be in order. The patient was sent to recovery. I was called approximately an hour later. I was in delivery with a patient that was pushing, and the PACU nurse said that the patient had started bleeding, say 30 minutes previously, and was currently soaking a pad every 15 minutes and needed you to come evaluate her. You said, I will be there as soon as I finish this. Or could you have sent somebody else to check on her, or was there no one else to check?
So I,
Maybe the way you need to spin it is
mhm,
that PACU nurse didn't, you know what I mean? There's nothing wrong with what you did. Okay, let
okay,
me just say
okay,
that. There's nothing wrong with what you did.
okay,
Okay, now let's go back to how could we make this sound even easier for you to
yes,
defend? That you were in with the patient, you were in with the patient that was pushing, you went in, you saw the patient prior to, then patient was fine, your OR patient. Then you went down, you were in the middle with the patient who was pushing, you get a call from the PACU nurse who says the patient has started bleeding vaginally and she soaked through a pad in 15 minutes. And you said, I will be there as soon as I get this delivery done. And she never said, oh, you need to come sooner.
okay,
Make it sound like that. So just say
okay,
when you went up there, you were surprised that the amount of bleeding that had been going on had not been communicated to you. Just say it that way. So
okay,
then and then just everything, you tried to evaluate by bedside. The patient really didn't want to go back to the OR, but you really could not tell what was going on. Talked to anesthesia, took the patient back, gave her some sedation. You closely looked at everything and you were able to see, I would say, two small cervical lacerations that you were able to easily stop the bleeding with, basically like a figure-of-8 suture through both of them after you had removed the blood clots, and just say, I truly I don't have an explanation for why this happened. I do the hysteroscopy DNCs the same way with all of them.
hmm,
She was not bleeding when she went to PACU. I truly don't have an explanation. Now, if this woman told you that with both of her pregnancies she had a postpartum hemorrhage and then she had this bleeding, although she had a laceration, what would you think about working her up for now?
oh, then I would be worried if she has some kind of clotting deficiency, like the bone brand or sort of.
Exactly. Because yeah, exactly. Because that's one of the things even though she's older, if especially if she had said both of my kids I did postpartum hemorrhage, and then you're like, okay, this was a lot of bleeding for this too, and it kind of started afterwards. I would actually think of, do I need to check her coags? Do I need to check for von Willebrand's? But I think it was just, I don't know why it did what it did.
Yeah. And my only other thing is that, when we look at these tenaculum sites, the speculum is still in there and putting pressure on part of that cervix vaginal wall. And I don't know if
You know what?
once I, you know,
That's a good thought. That is a good thought. What could there possibly be some compression of the arterioles, or the little small branches of the artery that are
mhm,
compressed from the speculum? And that is a good thought. Do
okay.
you inject the cervix at all, or with anything?
I started since this. I didn't before.
And what do you
So
inject it with?
I do the lidocaine and some of the lidocaine with epi.
Okay. And I guess that would be, but then again, if you really did that, once the epi wears off, if she was home with a laceration, maybe that'd be worse.
That is true.
I'm just teasing you. I'm
Yeah.
teasing you. But anyway, but yeah, because it's one thing of the tenaculum site, but it's another thing if there's a laceration. So if they asked you about the laceration, you know, in my head, I'm thinking like where you put the tenaculum in, now you kind of rip through the entire cervix. And that's not the case. It was just the puncture site was a little bit bigger than what you thought, right?
Yes.
Or did it tear all the way through the lip?
No, no, no. It was just right. It connected the two tenaculum sites. Like, you know how there's two teeth? They were connected,
Yep.
like there was
Yep.
that small laceration.
Okay. Yeah.
Not
Yeah.
painful.
So make sure because to me, when I think about cervical laceration, I'm thinking your tenaculum like tore all the way through the lip, and it didn't. You're saying no, no, no. It was really where the two teeth went in. That
Yeah.
was what was. Yeah. And so make sure you describe that. If I don't even know if I'd call that a laceration, you know what I mean? That you just described that better of how small that area was and why when you looked at it, it wasn't bleeding.
Okay. Yeah. It's just
Right.
that amount just throws me off, like 750. I'm like, oh my God.
Yeah, but you can explain it that you were told that there was some bleeding. You were in the middle of delivery. The amount of blood flow had been underestimated to you when the phone call occurred. As soon as you finished the delivery, you went up there, got her back, took care of it. Now, was she symptomatic afterwards? Did she need a
No,
blood transfusion?
no.
Okay. Did you, after you, with that blood loss, did you repeat a CBC before she left?
Yes.
What was it?
She started with 12 and it was like 11 point something. I know sometimes they're not as accurate given that it was just within a couple or 3 hours from her first initial draw.
Yeah. So then that almost makes you wonder, was it really 750 cc's if it was 12 and then she was only 11 something?
11, yeah, like 11.2, something like that.
Yeah. So that would be the other thing to say. Just say, in addition to this, another thing that doesn't quite make sense was her pre-op H&H was 12, but her after this bleed, her post-op H&H was 11.2 or something. So geez, that doesn't quite add up in my head.
Okay. And that's why I put EBL rather than it wasn't quantified. What was really quantified was when we went back to the OR. So the rest was from the PACU.
The pads, soaking of the pads and the nurses, etc. So I would say this may be an overestimate because this was not measured. This was by a soaking of a pad and what the nurse described to me by the time I got up there. The only part that was quantified was when I was back in the OR. And when you went back to do her repair, how much blood loss would you say there was?
I would say maybe about 50 to 100.
Yeah, so just say in the OR when I went back to repair it, I had 50 to 100 cc's. What is reassuring and would kind of go against that 750 cc's estimated blood loss is I would use your hematocrits. I don't think it was that much.
Okay, got it.
Okay, all right. See, sleep tonight. You'll sleep tonight.
Thank you.
Okay, all right, thanks. Hey, Brittany, how are you?
Doing well. How are you?
I'm just groovy. Are you a general OBGYN?
I am.
Okay. And when do you test?
In December.
Okay. And what state do you live in?
I'm in Texas.
Okay, another Texan. All right. Yeah, oh, I came out of my exercise class today and I met some woman for the first time. I said something. She goes, "Are you from Texas?" And I'm like, "Texas? I'm like from Michigan. I have a nasal accent. Why would anyone think I'm from Texas?" And I'm like, "No." And she's like, "Oh, I thought I heard that nasal," or she said, "I thought I heard that Texas twang." I'm like, "No, you're hearing nasal Midwestern, but whatever." Okay, so do you have a particular case list you would like to go over?
No, your choice.
All right, well, we haven't done any office tonight. Would you be okay with that?
That's fine.
There was a little hesitation there, Brittany.
It doesn't matter at this point.
I'm just giving you a hard time. Okay, this always you're probably down at the end. Sometimes these take a
Yes, I'm under
while
the
to
S.
load. This is not loading, the office one. Let me go. You might get out of office. Do you see what I'm saying? When I'm going down, it's not loading past J. Let me try. We haven't
Would
done
it make a difference if mine were uploaded in October?
It might. But see, then this one is loading just fine. See, and here you are here, so I don't know why that one's not loading. Are you okay with the OB?
That's fine.
All right. Do you have any particular horror case you want to go over?
No, not really.
Okay. All right, I'm going to try to scroll further toward the back because we always, grab the ones toward the front, and the back of these case lists always get neglected. Well, let's look at 57. She's got all kinds of good crap. All right, patient 57, 24, G1P0 at 39 and 3. So she's term, nullip. She has polyhydramnios with an AFI of 31. So what's the risk of polyhydramnios?
If she were to rupture membranes prior to labor or outside hospital, she'd at increased risk for cord prolapse.
Okay.
We would be more concerned for something such as diabetes or a potential infection, such as torch infection in pregnancy.
Okay, so let's go back to
postpartum hemorrhage.
Yep, definitely increased risk for postpartum hemorrhage. So if she's at home and she gets this, she has spontaneous rupture or even PROM before she starts contracting, and all that fluid comes flying out. Cord prolapse is definitely one thing, but what else could happen with a rapid decompression of the uterus?
Placental abruption would be concerning as well.
Yep, absolutely. So and then what else? With all that fluid, how can that affect presentation of the fetus?
Sometimes you can see a category 2 strip with potentially recurrent variable decels or even late decels if it is in the presence of abruption.
Okay, so let's say the fluid's still there and this baby is swimming around in all this fluid. Do you think that was any possible cause of her brow presentation?
Potentially, yes, if the baby didn't go through the normal engagement process.
Okay, so tell me, with regards to polyhydramnios, she started telling me a little bit about some of the causes. One would be diabetes, one would be infection. What's the most common cause of polyhydramnios?
Unknown cause, actually.
Okay, yep, exactly. So 50% is just going to be idiopathic. Are there any congenital anomalies that can cause polyhydramnios?
You would get concerned with some of the GI complications, such as duodenal atresia or even some of the esophageal abnormalities where you have a blind pouch and you can't transfer the fluid down into the GI system for the baby to urinate the fluid out.
Okay, so tell me about a brow presentation. How do you manage that?
It depends on the orientation of the brow presentation, particularly where the mentum is. And so when you have a patient that has a brow presentation and the mentum is posterior, that would be a contraindication to continue labor for that patient.
Okay. Why is mentum posterior a contraindication to vaginal delivery?
Because the head of the fetus is already in a flexed presentation, and through the process of uterine forces and contractions, you could have an injury to the baby, but also dystocia of labor because the baby's unable to undergo cardinal movements.
Well, when there's that when mentum is posterior, if you think about this kid's coming, now the head's actually, you said flexed, it's extended actually,
Excuse me,
right?
yes,
'Cause
yes.
yeah, so it's no pelvis, unless this was a super premature baby, can fit extended head, shoulders, and everything trying to enter the pelvis at the same time. Does that make sense if you try to think about that? Whereas mentum anterior, what's different about that?
Then through the process of labor and descent, the baby can actually have some flexion to where it could fit through the birth canal.
Okay, perfect. All right, so then, so you went ahead and induced labor. What did you do an AROM, or did you let her spontaneously rupture?
She had a controlled rupture of membranes.
Okay, what do you mean by that?
So in these patients, I try to have a nurse present to apply bundle pressure at the time that I'm making a smaller rupture in the membranes to allow the fluid to slowly release through the vagina and make sure that I keep my hand in place and follow that head down into the pelvis and allow it to be fully engaged so that I could also detect cord prolapse if it were to happen.
Okay, good. All right, so then, so you did induction. When did you manually rotate the fetus?
So brow presentation was not actually diagnosed until the patient had started pushing with the nurse. I was called because she was not making a whole lot of progress. Our office is not attached to the hospital, so oftentimes the patient will start pushing with the nurse while we're en route. When I got there, the nurse had noted that she had not had any descent. So I examined the patient and noted that the brow was the presenting part. And at that time, I was able to manually rotate the head of the fetus, and we effected delivery within 30 minutes after.
And so tell me what you actually did with the head. So if the brow was the presenting part, what were you rotating?
So in this situation, she had good anesthesia, and I was able to insert my entire hand, and I was able to feel the occiput in the left posterior position. And so with my thumb on one side of the occiput and my remaining forefingers on the opposite side of the occiput, I was able to flex the head anteriorly and then rotate to anterior. And then I allowed the patient to push to kind of engage the baby's occiput.
That's excellent. Okay, so then you're thinking, huh, I'm a good OB. And then what do you get? A friggin' shoulder dystocia. Okay, so now what do you do? And you're like, is this kid ever going to come out?
Yes. So the first thing that I did was I instructed the patient to stop pushing. We did McRoberts position, and then I had the nurse apply suprapubic pressure. And I was able to, within about 30 seconds, deliver the anterior shoulder after going back to downward pressure.
Okay, so really with just McRoberts and suprapubic, so it was pretty easily delivered, right?
Correct. Correct.
Okay, so with that easy of a shoulder dystocia, how would you recommend this patient deliver in a subsequent pregnancy? The baby really wasn't that big. How are you gonna counsel her for how she should deliver next baby?
I would counsel her that the risk, although slightly increased above average because she's had one previously, is actually pretty low in subsequent pregnancy, and that it would not preclude her from being able to have a trial of vaginal delivery.
Can you think of any instance where you would not recommend a vaginal delivery after a shoulder dystocia?
If the baby had had an injury, particularly a permanent injury, and the patient, just from a psychological standpoint, did not want to go through that again, or if she had had significant tearing, such as a third or fourth degree laceration, or if it had been a prolonged shoulder dystocia, I would counsel her that she would have an option for a primary cesarean section.
Okay, good. So let's say if the baby had not delivered with those two, McRoberts and suprapubic, what would have been your next go-to move?
My next go-to move is delivery of the posterior shoulder, if possible.
Okay. What would you do if that didn't work? Or let's say what would you do if you couldn't get truly your hand just could not get in there to sweep that shoulder out?
The first thing I would assess do I have room to place my hand to do that? If I was not able to, then I would cut an episiotomy just to allow access to that posterior arm.
And what kind of episiotomy?
I do a midline.
Because
partly that was how I was trained, but also decreased morbidity as far as blood loss, significant laceration, and not significant laceration, breakdown and pain with dyspareunia.
Would you be more worried though you could potentially get a third or fourth degree though with that, especially with possibly a big baby?
Yes.
Okay, but you feel that the benefits outweigh the risk of doing a midline?
Yes.
They might argue with you a little bit on that one on a mediolateral protecting her sphincter more, but I totally get what you mean. I was totally trained in midlines also. So that I guess that's you could just talk about that would be your judgment call. All right, so let's say you get the posterior shoulder out and the baby's still stuck. So now what are you going to do?
I would try a rotational maneuver at that point, where I would try to rotate the anterior shoulder posteriorly 180 degrees and try to disimpact that shoulder.
Okay, still stuck. You know I'm going to take you down the whole path.
Yes.
So just keep telling me what you're going to do till we're back in the OR and you're doing something, okay?
Sure. The next thing that I would consider doing is doing a fracture of the clavicle. And if that didn't work, I would try all my maneuvers again. If it did work, I would still try all my maneuvers again. If that didn't work, then I would go to the other clavicle and try to break that one as well and then repeat all maneuvers again. If that didn't work, then I would, of course, have already called in extra help to the room, a second obstetrician, anesthesia, and would call to move to the operating room.
And then what are you going to do? What would be your first? Well, now you're in the OR. What are you going to do?
So at this point, I would attempt a Zavanelli maneuver.
Go ahead. All right. Have you ever done one?
No,
I've never done one. Yeah, I've never done one either. So here's the thing. Because I've never ever had a shoulder dystocia get to that case, all of us are guessing at what we would do. I don't know of any candidate in all the years of doing this who's ever really had a shoulder dystocia get to that point. But in order to do a Zampanelli, we still have to make a hysterotomy, right? Because that's how we're going to get the kid out is by basically taking it out through the uterus. So you're going to open her, you're going to make an abdominal incision, you're going to make a uterine incision, and I would say prior to doing a Zampanelli, I would try to put direct pressure on the anterior shoulder and see if you could push it underneath the pubic bone. I would do that first.
Okay.
Then, if that didn't work, I guess you go to Zampanelli. But hopefully you can just, with direct pressure, you know what I mean, push it under the pubic bone. Now, the only thing I want to tell so you did great. I think you did a great job. So what we're going to finish up with, there was as part of our maintenance of certification, we had to read, and I talked about this on one of the webinars, I think maybe last month or the month before, and a lot of you weren't even on those ones, but in our maintenance of certification, there was an article we had to read, and I think it was in the Green Journal, that talks about using the shoulder shrug maneuver with shoulder dystocia. So let me see if I can explain this to you. All right, so let's say you've done your McRoberts and your suprapubic, baby's still stuck. So before you would try to deliver the posterior arm, you would take like your index finger and your thumb and try to put it around the posterior shoulder, like where your finger and thumb would come together in the baby's axilla, and you would pull up on the shoulder like you were trying to shrug it toward the baby's ear, and then you're holding that with one hand, you would try to rotate that shoulder anteriorly, like so you're trying to spin the baby. So now that shoulder's way up by its ear, and when you turn it, it's already past the pubic bone. Does that kind of make sense, what I'm trying to explain?
Yes.
Okay, and so that's called a shoulder shrug maneuver. So when I was describing this in this article, I'm like, I've never tried that, but I was trying to envision the physics of it. I'm like, oh, that could kind of work. One of the candidates who was on the webinar said she had actually gone to an emergency OB, obstetrical emergency conference. And she said they actually talked about doing a similar maneuver in the with shoulder dystocia, and they actually recommend it. And she said what they said is if you can't even get your thumb in your forefinger around, they will like loop a red rubber catheter around that shoulder and kind of use that to keep it pulled up and close to the baby's ear while they rotate it. So I just thought that was interesting that she said in that emergency class they were actually teaching that as a possible maneuver. ACOG just did a recent practice bulletin on shoulder dystocia. They don't even mention anything about that. But because they had us, the OBGYNs that were already board certified as our maintenance of certification, that was one of the articles they picked for us to read. I kind of just wanted you guys to at least have heard about it. So if they ask you about it, which they may or may not, now you know.
Thank you.
All right. Okay, thank you, Brittany. All right, so I'm going to lower everybody's hand because we are definitely done for the night, and I will just scroll through and see if there's any last minute questions or comments. I will be doing case list review again on Tuesday with you guys, so. All right, I think we're all tired with this daylight saving times change or whatever. Okay, I'll talk to you guys on Tuesday. Thanks so much for attending the webinar.